Europeans have experienced the lockdowns, the isolation, and the economic hardship. I think more and more we're seeing how COVID really is the great revealer. The isolation, it reveals inequity. It shows issues around wealth, gender, race, we're seeing how COVID climate. It's as though the virus is saying something to us. You want to get on top.
Greetings, friends and colleagues from around the world. I know it's 8 o'clock in the morning for our US colleagues who've just woken up after an exciting evening, 1 p.m. in UK, 2 p.m. in Paris, and our friends who are listening in Nepal, it's in the afternoon. So welcome everybody. This webinar series is part of the webinar series organized by the UK Faculty of Public Health in collaboration, European Public Health Association, the ethics section, the law section, and the general section, and Temple University, a number of other partners. And the basic purpose is that to link scholars, lawyers, practitioners, and policymakers, because public health law is not an issue just for lawyers, but it's an issue we all need to become familiar with, and we've learned this particularly during this pandemic. The session will be recorded, and it will provide a resource for public health practitioners, scholars, and students and others to learn more about legal epidemiology, which has been an issue which has been practiced a lot in the US, and we have a number of very distinguished scholars on the issue who will share with us their experience and learning about the issue so that we can now apply it in other countries. In the light of, we've had significant interest in this particular webinar, so there will be a quick poll on just to get a quick glimpse of our participants, and I'd be grateful if you could kindly have a quickly look at this and complete it. And if Deborah could kindly put it on, this is only 4 questions, so if you could kindly complete the poll, and then we can move forward with that. We have as I mentioned, we do have a number of, and as many people are Zoom experts now, so any questions and comments, etc., are on the Q&A box, and there is also a hashtag for people who may wish to use in terms of social media. We do have a number of distinguished speakers with us today, and so it will be tight in terms of of timing. Could you move to the next slide, please, Debina? Deborah. Thank you very much indeed. If you could move to the next slide. Thank you very much indeed. We have a number of distinguished speakers today, and I'd first like to introduce Professor Scott Burris. I'm not going to give detailed introductions for each of the speakers because they are distinguished speakers, and Google will provide you details of their distinguished careers on that. But Professor Scott Burris, who's one of the leading scholars on the issue, has kindly coordinated with the faculty this particular webinar. He's Professor of Law and Director of Center for Public Health Law Research at Temple University, and not only a leading scholar, but also a huge advocate for public health. He's a friend and supporter of research in the European Association. He was awarded the American Public Health Association Law Section Lifetime Achievement Award, and last year became the first fellow awarded for his distinguished of the UK Faculty of Public Health. So it's my great pleasure now to first Scott Burris to talk about legal epidemiology, what it is and why it's important, particularly at this time. Thank you, Scott, for taking us through this first session.
Thank you, Farhang. Let me just confirm that everyone can see my slides. Having just a little bit of funniness on my Zoom presentation here. People can hear me and see my slides. Thank you, Matthew. All right. Well, yesterday it was announced by our new president that Anthony Fauci will be leading the delegation from the United States to the WHO Executive Board this month. And I hope that's symptomatic of a return to real engagement from the US with the global health community. I also think it provides a nice opportunity to introduce this webinar, which is about an idea in public health that has been brewing substantially in the US, not exclusively, but it's something we've been working on, and a number of the speakers here have been working on now for some time in the US, which is good news, I think, for public health. We are certainly all aware in public health of the importance of law as a mechanism for making health better. But now, and for the last 10 years or so, we've been trying to think much more systematically about law as not just a nice thing for public health or as an occasional tool that public health uses, not just as a sort of ancillary or related field, but as an integral part of public health practice. An integral part, not just in the sense that you can't do public health without law in the modern world, but integral in the sense that legal capacity, legal understanding, and legal work is actually part of the job description of most people in public health, regardless of their primary professional training. So this is my little ancillary or starting exhibit here, just a reminder of how important law is in public health, in this case in COVID, our theme of 2020 in public health. This is simply a polar chart capturing COVID-related emergency orders in the United States, in the 50 states. And you can see that in March, at the beginning of the awareness of the epidemic, there were just very few states that had just done a couple of things like gathering bans. Within a month, almost every state, numerous things, including travel restrictions and closing businesses and so on. And then this is part of the story part of the tragic story we don't have time to go into. Just 2 months later, a lot of that had already started to fall away with the kind of consequences that you're all aware of. But the point here is that that was a great example of how suddenly everybody was quite interested in law. And I mean everybody in all sorts of respects: politicians, citizens, people who own businesses, and of course, those of us who work in public health. And we all found ourselves with some pretty significant empirical questions about what was going on, from what's working, which of these measures is having what kind of effect, or even theorizing what kind of measures might be expected to have various effects. Epidemia, not just the mechanics and impact of the of the intervention itself, but the social science of the intervention. How, and that's the big word, how do we change social attitudes about masking? We know we have social attitudes about masking. We know they are really important to compliance with masking advice or even masking orders, but where's the knowledge and the evidence base for changing whatever attitudes we happen to be stuck with at the time that we start a major epidemic response? What are the side effects of these kinds of public health measures? So we have a goal when we do a public health legal intervention, but just like when we give somebody a pill, achieving the goal doesn't exhaust the set of questions about the effect that pill is having. And quite practical kind of calibration implementation questions, such as, is it better to have high fines for violations, like say they did in Spain, or to count on the honor system, as many other countries have, like the US? And these are not, that's just the tip of the iceberg in terms of important questions, because when we have watched the unfolding of COVID at a national and global level, we have seen how it highlights underlying existing inequalities. And of course, we're quite concerned as people in public health about focusing on those kind of deeper social determinants of health so that we can deal with problems upstream rather than try to cope with them downstream. So the level and distribution of COVID harm and its relationship to social structure and social conditions and access to social resources, but also, of course, how does the secular social condition of a country, its social structure, its political structure, its governance, influence the actual capacity to respond and the nature of the health infrastructure? These, I want to emphasize, are also legal questions because of two important characteristics of how law behaves in the world. One is that law is constantly acting on people according to their underlying social position, according to their starting point. Law may treat a neutral law that says the same thing for everybody, may have very different effects, and may treat very differently people of different social classes. So when we say, let's have everybody work from home, that has a very different effect on people who, like me, are academics who would rather work from home, and people who are service workers who can only work in their setting. And of course, the way that work looks and the way the resources to cope with a shock like COVID have already been distributed is also a function of law. Law creates our social institutions. It establishes rights, and it sets up essentially structures opportunity for all sorts of social benefits. The tax code determines, where the money is redistributed, where it starts, how easy it is to get an education, how that education is paid for. So these things all actually influence the underlying social conditions that we're concerned about. So the level of attention to law in COVID is perhaps new, but the interest in law and the recognition of law as an important factor of public health is not new at all. This is my standard slide on that point. The great achievements of the 10 great achievements of public health in the 20th century, according to the CDC, all of them had some legal elements, some primarily legal. It's hard to imagine, for example, motor vehicle safety without a comprehensive set of legal interventions that I will ever, and yet it was one of our hugest successes in reducing morbidity and mortality. So the point here, in part, is that public health law is not just an intervention tool. It is one. So those safety belt laws and clean indoor air law, those are big wins for public health. They have a big effect. But this is law being used explicitly as an intervention. But we're also interested in infrastructural public health law. That's the law that establishes the nature, powers, jurisdiction of our health systems. And therefore, ultimately, their influences their capacity in dealing with health, or major questions like what drugs we can get and when we can get them. But probably the most important part that I want you to keep in mind as we go forward is what we call incidental public health law, which is pretty much everything else. It's all that law that is doing that structuring of society and doing that sorting of people to different kinds of health outcomes in itself talking about law. So in our country, the number 1 and 2 factors, I would say, that have led to our unprecedented level of income inequality over the last 30 years has been changes in tax law and changes in employment law. No so-called health law has had more impact on the health of Americans than these laws that don't mention health. And of course, if we're talking about changing social determinants in Europe, in Africa, in Asia, in the US, you've got to be talking about these underlying structuring legal forces. Now, the second part of legal epidemiology, after we're all in it, we're all doing law and public health, is that public health law is readily amenable to evaluation using the same basic science we use for looking at any other kind of health intervention or health force in epidemiology. And we've had great science in areas like tobacco control, road safety, and alcohol control in interventional public health law. But there's too many areas of intervention where we haven't had that work. And more importantly, there's a lot of areas of incidental and infrastructural that have never really been fully. The problem is that basic education in public health law in our health training programs is rudimentary, sometimes even, I think, kind of counterproductive. And many areas of importance in public health, like regulatory design and enforcement, are not covered at all in health training, even when we're training the people who are going to be going out and enforcing our health and sanitary laws. Oftentimes, very unhealthy law is left substantially unevaluated and allowed to fail for years and years and years and years. And the International Drug Convention model and its national avatars is a perfect example of that. We have had 40 years of a war on drugs, and we've lost every year, every battle, and continue to do so. And not just that, because this is the important aspect of thinking about law as a force for health, not necessarily intervention. Law can create harm, and the social and individual harms created by the current approach to drug control is a classic example and an extremely well-documented example of a system where there is definitely a health problem to be dealt with, but the way we've chosen to deal with it has perhaps caused as much or more harm than the problem itself. Fundamentally, the problem is that we are groping in the dark when it comes to law because we have not done the science that needs to be done. So typically, the norm is that law is not developed, implemented, or evaluated in any way with a strategic or systematic empirical perspective. So we don't know whether and how it's working. We don't know whether it has side effects. We don't generally even know where it has been adopted. All you have to do as a thought experiment is to recognize the absurdity of that, is to imagine if we treated drugs that way. Now, laws aren't drugs, and there's a lot of different kinds of challenges in evaluating them, and typically we're always going to be behind. We're always going to be looking at laws that have been implemented. But that doesn't change the fact that with more focus and more funding, it would be possible to understand the effects of health laws much more quickly and to anticipate their effects much more successfully. Now, of course, one big reason, as I've mentioned, is, as I probably already suggested, is the health establishment has not funded that kind of research. 200, if you just look at the last, this is a graph that shows grants issued by the National Institutes of Health in the United States over many, many years, over 25 years or so. You can see that in the last 4-year study, NIH gave out nearly 220,000 grants for research, extramural research. Only 247 of those, as far as we could tell, dealt with any kind of legal question. Law is a lot more important than 247 out of 220,000. And I think this reflects a broader cultural problem in public health that I think legal epidemiology is trying to address, and webinars like this address. Part of why public health doesn't deal with law, I think, effectively, and this is based on 30 years of anecdotal life, is just the yuck factor. People think, many people in health just see, I don't like it. I don't want to deal with law. It's too messy. Another is I suppose you could say, the the belief that law is needlessly complicated, if not comically complicated. And if you want to get anything done, there are better ways to do it than trying to figure out such a system as this. And then finally, there is also a little bit of the not my job problem. You know, I'm a public health person. I paint the line. I don't move the tree. Somebody else should move the tree. Our point with legal epidemiology is law is not that complicated. It's understandable. It's actually quite useful to us, not yucky, and it is part of our job in public health, no matter where we primarily rest our hats in terms of professional training. So the idea of legal epidemiology to try and promote that work came from initially from a program funded by Robert Wood Johnson Foundation, and then I think was really, as you'll hear, led from CDC, by the Public Health Law Program that coined the term legal epidemiology. We call it the scientific study and deployment of law and legal practices as factors in population health. It starts with a very broad view of law. Obviously, all those positive legal documents, laws and regulations and executive orders and so on, including also public finance. But law is also takes the form of internal rules, operational rules, standard operating procedures, organizational rules that are observable as legal texts. And both public and private rules of that kind are relevant to what we think of. And also, you might think of legal practices as being legal inputs that we can study profitably to learn their relationship to health. And that is where we want to get. Once we have got law, we start to see these outputs. Law produces legal activity, legal behavior, legal practices. It produces changes in behavior. It changes in environments. There's some reciprocal impact there. And ultimately, it all goes to health. And what we're talking about in public health law research is to get everything on the red side properly measured so that we can understand the effects on the blue things and the green things. And that is, after all, ultimately normal science. We can use different tricks, but fundamentally the same techniques to study law as a factor in health. As an example of how this kind of legal and science interchange can happen, I point to what we call policy surveillance. This is the idea that we can scientifically measure and track laws of public health importance for the same reason that we track disease outcomes, because they are of ongoing importance to us as factors in public health. But the science part here is that we've shifted in doing our legal measurement from the way lawyers do it, which is to take one page of law and create a 5-page memo explaining it, instead to transform the text of law, the operational features of law, into numeric data that can be put into a longitudinal data set capturing these key features, which then can be put into a larger quantitative analysis. Second feature of legal borrowing from public health is and science is to have a transparent and reproducible method for measuring law. That's just an example of how a model like legal epidemiology is about sharing and borrowing and integrating rather than parallel play between two distinct fields. So ultimately, the focus of legal epidemiology is on at least three elements. The study of this incidental public health law, so law, a kind of epidemiological study or legal etiology of law, trying to understand the impact of legal interventions and the impact of legal infrastructure on the success and launching of those interventions, and finally having better tracking and measurement of the effects of law across time and space. All these things are things that non-lawyers do, but the things that lawyers, all the traditional public health law practice elements that are crucial to effective use of law in public health and which require the integration of lawyers into the story. And we put that together into what we call the transdisciplinary model. Transdisciplinary in the sense that it is not about multiple parallel activities, but the true integration of methods, tools, and theories, law becoming part of the core of public health. To capture that further and to illustrate why that's important, we borrow the idea from public health of essential operations or essential services, and we create the 5 essential public health law services, which are the things you have to be sure you're doing if you want to do law properly in public health, and which also happen to capture the sort of life cycle of law. So it starts with thinking about policy design. Lawyers are not the ones designing policies, normally speaking. Usually they are actually public health people who are not lawyers, who are figuring out what this is the Haddon matrix, which is a wonderful tool for systematic policy design, which was what drove our highway safety law in America for decades, and which borrows scientific approaches to avoiding bias and path dependency in policy development. So we can do a better job designing policies. The idea of taking a policy and putting it into law may seem like an afterthought, but it's crucial, because what lawyers do in taking a policy idea and finding the best legal form for it usually sets the course in terms of its politics, its political fate, and also its legal fate in subsequent challenges and its enforceability. All legal instruments have to be adopted. Public health people must be advocates. We all know that. And most of the advocacy in public health will not be done by lawyers. So if we're not teaching and empowering our public health workforce to also understand and participate in advocacy, we're missing a crucial service in public health law. Once we have that law adopted, it's actually got to be implemented and enforced. There's a restaurant inspector. That restaurant inspector has no legal training, and yet that restaurant inspector is a primary regulator and will be wielding legal power. We also, of course, realize, and this is where lawyers come back into this, that a lot of the times the things we enact are immediately challenged by industry. And so there's an ongoing legal battle to show that the intervention is legal and that it's effective. And that's where we get back to the whole question of evaluation and policy surveillance. We must be more like pharmaceuticals in that we are watching the effects of laws out in the world, looking for side effects, and plowing that evidence not only back into, say, defending a law against a legal challenge, but in designing law. What can we learn about the mechanisms of effect from law A that we can use later for law B? There's nothing new here. I want to emphasize this. This is more just taking old public health principles and old public health practices and making them explicit in the manner of essential health operations. How do we make sure we're doing these things and do them well? And how do we strategically coordinate them more consciously so that we have the greatest possible effect and the fastest possible effect? If we can get a good law spread in 5 years, we save a lot of lives compared to taking 20 years to spread it. So today we have powerful examples of how this legal epidemiology can work in action. My colleague, Dr. Comroe, will be talking about how you use this approach and good, well-measured legal data and great methods to understand deep drivers of social inequality in our social benefit system. Dr. Van Rooij is going to talk about how he's tried to help, and he and his colleagues have tried to help us understand what's going on with COVID as fast as possible and to apply evidence in that cause. Dr. Kavanaugh is going to talk about something which I wish we'd had 30 years ago. So I'll say no more about that, but we've needed it for a very long time. And finally, Dr. Hearn is going to talk about some really innovative ways that we can use data and tried and true advocacy approaches to make some powerful effects on city level policy. And finally, and maybe most importantly, Matthew Penn from the CDC will talk about how legal epidemiology is being institutionalized at the beating heart of American public health. So I will now turn it over again to Farhang and our wonderful set of speakers.
Thank you very much, Scott, for an excellent introduction and a background, providing background and context for these excellent examples, which we're now going to have. The session is being recorded. It will be available for everyone on YouTube as well as that. And if you want more sort of information around the specific issues which Professor Boris has highlighted, we will develop a little portfolio of information about these ones which we can share. It's a great privilege now to introduce Professor Kelly Comroe, who is a social and behavioral epidemiologist focused on promoting child and adolescent health And while she's sharing her screen now, I was fascinated that in her portfolio, she talked of her meaningful and humble experiences partnering with diverse families, schools, and communities, which have fueled her passion for legal epidemiology. And I thought it was a wonderful set of words which would describe her work as a serious scientist on this issue. Professor Combrough, thank you.
Thank you very much. And thank you, Scott, for that great introduction to legal epidemiology and the importance of it. And my work indeed is inspired by my previous work in public health. I really focused on child and adolescent health, and I'm actually an experimentalist. For most of my career, I've conducted group cluster randomized trials, so partnering with lots of different communities across the US. And from that experience, I guess you're just really hit over the head all the time of the importance of the social determinants of health. And so then very much inspired by the World Health Organization's Commission on Social Determinants of Health and this framework. And this framework really showing the power of policy in determining socioeconomic position and the conditions that families and children live in, right? And as determinants of health outcomes and health inequities. So this has really inspired my work, this conceptual framework. And then of course, I'm in the field of public health. And so some of the research that Scott highlighted, that the methods used, the very rigorous scientific methods that have been used to evaluate the intentional laws, right, around alcohol control, tobacco control, injury prevention. It was like taking those methods and applying them to the drivers of the social determinants of health. It's really the impetus of my work. And so driven by this overall conceptual framework of social determinants, this is just now more specific to a set of studies that I've been conducting over the last few years. And that has really pinpoint in on policies that we have in the US that influence family economic security. And this is the conceptual framework then of how those laws would influence health outcomes. And the series of studies that we've conducted have really looked at birth outcomes as just one indicator of health and health inequities. So the funded study, I was one of those maybe less than 250 studies funded by the National Institutes of Health to actually look at a set of policies that influence family economic security, and was able to get that funding thanks to Scott and his public health law program that provided initial funding for some pilot to get us going in this area of research and to show the reviewers at NIH that this was feasible and good science. So today, well, our contributions, I want to speak to this a little bit because this is all in the methods. So we are applying these strong public health research methods to actually analyze, to code the legal text laws across the US states, and then using rigorous quasi-experimental designs, right? So we have states that pass policies and states that do not, and we are looking at data before changes in laws and after. So we have the intervention and comparison states, we have the baseline and post-intervention time periods. We use methods, the difference in difference analysis and time series analysis, and I'll give you a couple examples of those today. We're using longitudinal designs where we're looking at changes in policy across time and across states, like over 20, 30-year periods. And we're not only looking at if there is a law, but we're really getting into the dimensions of the law and what we categorize as the generosity of laws to help support family economic security. So today, with my few minutes that I have, I'm going to give examples of a series of studies that we conducted on the US work tax credit, so the earned income tax credit. This was there is at the federal level, there's a U.S. Earned income tax credit initiated in the mid 70s, but really took off and enhanced in the 1990s when the U.S. was involved with reforming the social welfare programs. The individual states also began to implement earned income tax credits themselves beginning in the late 1980s. And this is where we're able to use the states as, and do the comparisons of states that have enacted these laws compared to those have not, and then also the baseline and follow-up periods. The earned income tax credit has been really described as the largest and most effective anti-poverty program in the US. And there is a growing body of research on the health effects. This, if anyone is interested in these policies and doing research on these policies, we recently have published this paper and provided the data set actually over a 40-year period. So we worked with Scott and his legal team, and then also a team at the CDC to code all the enactments and changes in the earned income tax credit laws across the states over a 40-year period. And these maps just show that there's been a lot of activity and changes over time in both enactment at the state level and also the generosity. So one of our main papers was a pooled analysis looking at changes over a 20-year period across the US states. And so we looked at laws following big changes at the federal level. So beginning in 1994 through 2013, so 20-year period, where we were looking at all the changes that occurred and then doing a rigorous quasi-experiment. This map is showing the dimensions. So you see all the states that did not have an earned income tax credit. And then we categorize the states or the EITCs in their level of generosity, whether there's two dimensions. It's like how big the tax credit is, and then a refundability dimension. So some states have an EITC that are not refundable, so that's just the tax credit. And then the ones that are refundable is if the tax credit goes above what a family owes in taxes, they actually receive a check from the government, so their incomes are being supplemented. Just quickly, this is the methods where we did a difference in difference analysis. Our main outcome is these infant health indicators, and we're looking at the effect of the state level EITCs. We are using birth certificates as our health outcomes, so we're able to control for some maternal characteristics that are available on the birth certificate. We also control for some county level indicators, and we are controlling for the differences between states in birth outcomes and also the changes over time. So we have a year by quarter fixed effect. So these are the main results summarized, and because of time, these are just different. We looked at birth weight in grams. This is the measure of low birth weight, and then gestation weeks. And if we just look at this highlighted blue area, we see that this is in comparison to states that had no EITCs. We see that the most generous, so those states with the refundability and the high refundability, saw the most reductions in the probability of low birth weight births. And these estimates are 0.3 to 0.8 percentage point reductions, which translate to 4 to 11% reductions in low birth weight births. those results are, for the average, so averaged across all the birth weights. And so we also thought it was important to look to see if the effects were similar by the weights of the babies. So this is a quintile regression where we show the birth weights. So these are the smallest babies here on the left, and then the change in the birth weight in grams based on the level of the EITC. This figure shows that any EITC is beneficial, so there's an increase in birth weight, and you see the most generous EITCs have the largest effect, and especially for the smallest babies. So these results, we like to translate them into what these 4 to 11% reductions mean. So with the most generous state EITCs that we saw at the time, leading to almost 12,000 fewer babies born, low birth weight every year. We also took a look, did a sub-study and took a look if these results differ by race and ethnicity, because Black women in the US have the highest rates of low birth weight. And in this study, we find that given their higher baseline rate, there was larger percentage point decreases, but when translated that, when accounted for that, it was the same effect size across the different racial and ethnic groups that we looked at. And then finally, I just wanted to give you an example of where we can also look at specific states as an example. So we looked at in Washington, DC, it was Washington, DC was a great example to look at because it's a high risk population. So there's the population, there's a high percent of families living in poverty. And then they also implemented 4 changes in their EITC. So they initiated it in 2000 and they kept increasing the generosity. And so we took a look at the results of that using a time series analysis. And this is what the results look like, where we see reductions in low birth weight corresponding with the increases in the EITC. And overall, it translates into, once we got to the 40% EITC, we saw a 40% decrease in low birth weights. And then we're translating this into the number of low birth weight births, fewer each year. And then finally, we do the translation of, obviously these have the results of our studies have high policy relevance. So there are organizations across the US that are then translating our study findings for policymakers. This is just an example of some of that communication. And our group is involved with not only looking at the EITC, but other policies that affect the family economic security. And there's my email if anyone is interested in receiving any of the papers. So thank you.
Thank you very much indeed, Professor Comro. It shows the power of law actually in numbers, which we seem to love in terms of public health as a whole. And it's very, very powerful. I'm sure that research colleagues in the UK and other parts of Europe would want to use some of these methodologies. Michael Marmot and colleagues with the Health Foundation released a report on these issues, but the legal measurements could be very, very helpful. It's a great pleasure now to introduce Professor Benjamin von Roy, who is Professor of Law and Society at University of Amsterdam, who's very much into implementation of law. He's done a lot of global work in China and elsewhere, but he particularly will share with us a systemic review of social distancing behavior in terms of the law. Thank you very much indeed, Professor Roy. I'll hand over to you now. Professor Roy, thank you.
Thank you so much. It's my great pleasure to be here in this community of public health and legal epidemiology scholars and also practitioners. Um, so I'm sort of an outsider here. My core research question has always been, how do legal rules come to shape behavior? Originally training in law, but increasingly after 20 years of research on issues such as industrial pollution, corruption, tax evasion, digital piracy, I've come to see that the way we as lawyers have been trained and think, and the way we shape policy may not be optimal. We as lawyers have a big stake in the design of the biggest behavioral mechanisms that we make. Yet most lawyers don't have much training in what actually makes people behave the way they do. So we have, in my eyes, behavioral novices being in control of a system that is supposed to shape behavior. So I think in that I really like the idea of legal epidemiology. I would argue, before I start my presentation, can we broaden this beyond public health? Because I think you can use epidemiological thinking to any aspect. So for instance, to Dr. Comroe, I think your kind of analysis, for instance, could also be done on how poverty relates to crime. And I know there have been many criminologists and economists looking at that. But I think also people from a more epidemiological background looking at, for instance, homicide rates and tax credits, that's fascinating work. It might already exist. Anyway, let me get to COVID then. So, oh, sorry, I need to, yep, here. So as a background, I don't know if you remember the pictures of oil going minus in the price of a barrel, pictures of empty cities. We've even seen mass demonstrations where everybody kept 1.5 meters or 6 feet distance. In its basics, as Deborah Birx also has said and others have said, to mitigate the COVID-19 crisis wasn't only dealing with a virus, it was really about changing very basic human behavior. The word social distancing in of itself is so unlike what humans do. We like to be close, not distance. In of itself, it's a really weird word. So when the crisis developed in Europe early March and in the US, my research team became interested in it because we saw that governments across the globe were adopting rules to change very basic human behavior. First, it started with advisory rules on hygiene, but later it became more evasive. Keep a distance, 6 feet, 1.5 meters. Stay at home. Rules that came at tremendous cost and also asked people to completely change their behavior. I don't think in the history of the world there's ever been a time where so many governments at the same time try to influence the behavior of so many people. So it's an ideal situation, if I can use that word, because of course it's not ideal, for people who study rules and behavior to look at, okay, what lessons might we learn here? Um, so we did a number of surveys where we tried to look at different variables that shape human responses to rules. And we looked both at what I call motivational variables, extrinsic motivations and intrinsic. Extrinsic, for instance, law enforcement, also cost of compliance and cost of violation. Intrinsic, social norms, attitudes, support for policy, etc. But also situational variables that a lot of people forget about. Knowledge of rules, the capacity to follow rules, but also opportunities. Can you actually break the rules? Do you have opportunities to violate them? We built a survey that had all these different variables operationalized along a large amount of survey measures. And then we did surveys, we did a cross-sectional, but at different points in time in the US and Netherlands. And we are still continuing now longitudinal in the Netherlands. And we also did so in other countries. We have a whole bunch of findings that I won't present here today, but at the time when we finished these studies, we saw, okay, there's a large amount of research coming out. By June already, we saw that there had been nearly 80 other studies from other scholarly groups. So we tried to see, okay, what is actually the broader body of knowledge that we have here? Rather than only focus on my own work today, I wanted to focus on this broader body of knowledge. So what we did, we tried to do a systematic review, but we couldn't fully do it because a lot of this work was in preprint databases that don't really work well to completely follow the systematic method. It's really frustrating how many of these databases don't have proper search functions that you want to use to do a systematic review, but we did it as well as possible. Second, we focused on individual past behavior. There have been studies that have looked at inclinations. What would you do? But we chose not to focus on those. So some of the experimental work has looked has used vignettes, but we've not focused on that. We focused in this review on social distancing, so not on stay-at-home orders or on quarantine compliance or on hygiene. We focused on survey-based work. Reason for that is that it's the largest body of work. As I said, most experiments that have been published in the time period that we focused on were on hypothetical. And the objective data that has been out has been more aggregate level, and we were interested in individual level measures. We looked at both published and unpublished work, so pre-publications not through peer review yet, also because of the timing, a lot of work hadn't been out. And we looked both at formal compliance, where there was rules that were really legal, but in some jurisdictions, these rules had more of a guideline or advisory status. Of course, this also changed over time. And we focused on the first wave, so to speak, which was a work published that focused in the period March 1 till June 30th. I mean, not published, but came out. So if we look at the sort of Prisma flow diagram that we made to do the systematic review, we started with a larger amount of studies. We excluded, if you want details, you can look at the paper. But in the end, the number below is the most important. We had 45 studies. If you then look at these studies, and I have, it's not the full overview I see now here, but we coded them. We then also included a table where we include the sample size, country, the age, but also very important, the date that the data was collected. And this has a lot of effect. I mean, the closer you are to the measures being adopted, the difference the response is. So our longitudinal or longer time frame studies do show that there's changes over time, and this doesn't stay the same. But in the review, we weren't able to fully account for that. Maybe in follow-up studies, we can look at that deeper. We then looked at, okay, which variables have studies looked at? And this is a very interesting thing. What came out of this is that there was really a very high level of idiosyncrasy in the studies of social distancing. Our own designs were really focused on trying to understand compliance through every possible variable. As I just said, we had about 19 variables coming from a very diverse set of different theories. But we saw that depending on the type of discipline the scholars were in, their design was focused on particular variables. Psychologists would focus on attitudes, for instance. Political scientists would focus on conspiracy theories or political orientation, etc. That also means that we don't really get an ideal picture for practice. Sure, it's really nice if you know that conspiracy theories play a role, but you do want to control them for some other variables. So they have a very limited amount of controls, which also means that some of the studies, for instance, that find that political orientation is a good predictor, they don't link up well with studies that actually have more variables that don't find when they control for the other variables, it is a good predictor. And it's interesting that in the media, and I suppose also in policy, some of these early studies that didn't have a lot of variables have gotten a lot of press, even though their findings have not been replicated by studies who have more variables. If we then look at the most important table that we made, is we looked at studies that significantly predict compliance with social distancing measures. We looked at studies that found, we calculated the amount of studies when it was over 50% that had a significant finding, either that a variable was positively associated with compliance with social distancing measures or negatively. We have reported them here. So here for each variable, for instance, for age, we see that the older people are, the more likely they are to comply. So 17 studies find that, 3 find something negative, and 11 don't find an association. But because 17 is more than half of the studies, it's just a little bit more than half, we have here reported it. So it's a way in which you can see sort of what the different studies find. So if I go through this table and look at our findings, so I already mentioned there's an uneven focus. So there's more on attitudes, political orientation, threat on the virus. What is really surprising, there's hardly any studies, the only studies are from my own group, on deterrence and enforcement. And it's pretty interesting. The Dutch CDC just this week called me, even though I'm not a big specialist on public health, with advice on whether we should have a restrictions on going out in the street in the evening, whether that was enforceable. Why? Because within the experts that they do consult, nobody thinks about enforcement. So here's the thing where I think legal epidemiology can be in the middle. It's from a practice point of view, probably one of the first variables that you think about. But from an academic point of view, most people forget about it. Most specialists I see that advise governments on these measures are communication scientists from health communication, which is great, but they don't often have an expertise in enforcement and in the criminology of how to study deterrence. The other thing that was surprising also is that very few people look at opportunity. So if we look at some of the practical interventions that we've seen, it is about closing off parking, restricting flows through public spaces, restricting flows through shops, etc. Those are very powerful ways in which you take the choice away. And we find in our own surveys where we did include them that they're very good predictor of compliance. So what did we find that predicts compliance? Well, very naturally, fear of the virus. More fear, there's going to be more compliance. We see psychosocial factors. People that are more impulsive are more likely to violate rules. This is in line with general findings from criminology. And it has something to do also with age. We know that people are more impulsive when their brain is not fully developed and their system 2 is not fully online. But we also know that there's difference in personalities and that some people are more impulsive. We also know, of course, that alcohol plays a role. I mean, some of us may have seen the pictures from UK or US with drunk groups getting very close. Well, we also know negative emotions lead to more non-compliance. This is in line also with some criminological theories. I'm pretty sure there's also deeper psychology and psychiatric studies behind that. Social norms, again, not surprising. The more you see others break rules, the more you're likely to break rules. We see that here. We also see institutional factors. People that support the measures, this is also not surprising, will comply more. People that believe in conspiracy theories will comply more, and people that have better knowledge of the rules. So when there's better institutional spreading of the knowledge. Then we see, as I mentioned already, situational variables. People who know the rules, people who are able to work from their home, people who are not able to still meet with friends, people who can't go to work because work has actually told them to stay home. They're more likely to comply with the rules. We don't find in the studies that did look at deterrence, which are from my own group, we don't find an association with deterrence, which I think is an interesting thing to look deeper at. We've seen this across the samples that we studied in each one, except in China. And in China, the interesting thing is the rules were advisory on social distancing, so there was no deterrence. We're still finishing that paper, so if you're interested in that, I can talk about that. But we don't find that political orientation predicts, even though earlier studies did. But if we look at the body of studies as a whole, we don't see that coming out. And we also don't see that it matters whether people support the authorities generally. So it does matter whether they support the measures. We also, in the paper, mentioned some other variables that might require attention. One is uncertainty intolerance. We've seen from one study, but there's not enough replication, that there's an interesting finding there. Some people who don't like uncertainty are more likely to violate the rules. So let me come to my concluding thoughts. So first is we need way more systematic review. And this is a general thought for law. I'm doing another paper on how courts have dealt with the penological goals of the Eighth Amendment in US law, which is a very empirical question. Does a certain punishment deter? And what we see is that the Supreme Court in several cases really cherry picks the evidence, just goes for one one study, but if you look at a whole larger amount of studies in a systemic way, it becomes impossible to exclude evidence, and you actually weigh it in a more systematic design. And I think that's should be part for legal epidemiology, the systematic review, and if possible also meta-analysis, where we actually look across a larger body of studies to look at the empirics that should be the basis for legal design and legal policy. If we're going to do behavioral change through law, we need good research, but that also needs to have a good research design. And that's more of a problem in the research. We're very siloed. We're very much focused in criminology and psychology, some of the other studies, behavioral economics, on particular theories, on particular variables that we're isolating. But reality is not about these particular variables only. So we need better studies that more comprehensively look at this. This we also saw in the COVID research. It should also be more focused on practice. Fourth point is measurement. So if there's one thing that's impossible, it's measuring illegal behavior. There's always going to be a dark number, whichever method you use. So surveys, of course, we have social desirability bias. With experiments, we have that the experiments may be artificial, or that we can't really observe the illegal behavior enough. For instance, if you use government statistics on homicides, you may not have all the homicides, and homicide is still a good one. But if you're looking at other forms of illegal behavior, it's very hard to get good data, or it may be aggregate and you can't bring it back to individual data. There's always going to be trade-offs, and we have to be upfront about these trade-offs and make a nuanced discussion of them. So if you ask me for policy advice based on the surveys, the first thing I would say is, look, this is the blind man and the elephant. We get part of what's going on here. There's some evidence that surveys do predict real behavior, but we need other data points. So one thing that we've been doing is work with other research groups that use cameras, police cameras that have street level data on social distancing, and we combine that with social media posts that others have been having about their own behavior and about the policy. In that way, you get a rounder view of what is actually happening. Finally, if we have all that, we may say, okay, sure, we have the evidence. Now we can go to policy. What I see then is that we run into behavioral bias, as I call it. Everybody is human, everybody behaves, but not many people are trained in behavioral science. So what I see, for instance, with punishment, I mean, what was mentioned earlier about the war on drugs, most people have an intuition that stronger punishment in of itself deters. Even though the evidence for 40 years shows that we don't, the science shows that we don't have evidence for that. There's even evidence that's the opposite. But I still see if you show people that evidence, they're not going to take it for granted. So you're always dealing with an amount of bias in your audiences. Okay, I will leave it at here. This.
Thank you very much indeed, Professor Roy. You describe yourself as an outsider very much. I think you're an insider, particularly in multidisciplinary work and public health work. Everybody is part of the team, and with the new call for unity globally, you're very much an insider rather than an outsider. It's a great pleasure now to introduce Professor Matthew Kavanagh, who has actually collaborated with European Work and Public Association in the past. Professor Kavanagh is Professor of Law and Director of the Global Health Policy and Politics Initiatives, O'Neill Institute for National and Global Health at Georgetown University, who have collaborated with us with other webinars. So without further ado, I'd like to now give the floor to Professor Kavanagh.
Wonderful. Thank you so much for having me, and thank you to the organizers for making this fantastic event happen. So I want to start by kind of talking a little bit about the kind of project that is on our agenda today, which is on the AIDS, the world of HIV in law. AIDS remains a pandemic. HIV in some communities has become rare, but 10 million people have died this decade. And there are serious lessons as we think more broadly about pandemics, right? There are lessons to be learned, but also a warning that where we don't attend to law and the politics, what we see from pandemics is that they stretch sometimes for decades. And so as we think about this project, which is called the HIV Policy Lab, which is a joint project from Georgetown, UNAIDS, and the global network of people living with HIV and a growing set of partners, we've had two goals that really align with a lot of what's being talked about here. The first is to track laws to improve accountability for using law as a tool to fight the pandemic. And the second has been to really begin to empirically evaluate whether what we think matters, whether the kind of theory of the case that happens in global health about what will and will not matter at the global level, whether that actually holds. The science of HIV has actually been fantastic in recent years. We've seen huge breakthroughs, and that has been really, really helpful, and in fact should be applied by this entire UN agency, cross agencies, UNAIDS, that's completely dedicated globally to translating science into law. And what that might lead us to think, and I will tell you that this is what many of my colleagues who work in global HIV think, is that largely the laws and policies are right. They've mostly been gotten. There's a few areas, criminalization, that still a bunch of work needs to be done, but largely what we see is policies are right. It's just about enforcement and alignment. But in fact, we see that this is not the case as we start to look, right? And so here is one graph of a kind of global map on PrEP policies. And I'm going to talk more in depth about this, but this is, a key HIV prevention intervention where what we see is that across the world, countries have largely not aligned their policies and laws with what UNAIDS and the World Health Organization recommend. And so there is a lot of work to be done here in making this move forward. This, we argue, helps us explain why we have not made more progress on HIV in recent years, right? The goals that were set at the UN General Assembly in 2016, you can see on this graph are the dots, right? The green dot on the left for the number of new infections, the orange dot on the right for HIV deaths. The world is off track from even the not massively ambitious goals that were set in 2016. We're not on track to reach them. Our argument is that a key piece of that is explained by the law policy environment that's not being treated, as Scott described, as an intervention in the way in which it needs to be. So the HIV Policy Lab is a database and visualization platform. We've got 33 different indicators, legal and policy indicators that we're tracking across all 194 countries of the world. We've got 4 years of data and counting. And the core of this, the way in which we've gone about it, has kind of been 4 steps. First, we conducted a broad review of HIV-related laws and policy topics. You will not be surprised that there are hundreds that we could have, in fact, taken on, and be learning the lessons in part from Scott, which is you can't do everything, you can't do everything. We pared that down to focusing on 33 different pieces. We did that through extensive consultations. Our goal is to measure policy indicators and legal indicators of the legal environment, not to necessarily measure every single law. And then having done those, we then went about gathering the data. Now, this is a global effort, right? And so unlike strategies that look within countries or even within regions, our goal is 194 countries. So we can really get a comparative data set internationally. To do that, we use 3 different things. One, of course, we gathered primary sources. And I could talk at length about kind of how did we do that across nationally, especially in low-income countries. But we've been largely successful in being able to gather, using public health networks, the primary documents. But we also used information that was submitted by governments to UNAIDS and the World Health Organization, along with a meta-analysis of other published sources, so that we had the best picture we could of cross-national data to compare. And what we did is to say, for each country, can we answer each of the 33 different questions? So here are a few of the questions from South Africa. South Africa, it turns out, has the most aligned policy environment with international recommendations in the world. Far better than any country in Europe or the United States. South Africa has actually led on this and explains in part why they've made such remarkable progress despite huge burden from early on in recent years. And so what you can see here on the left is the kind of strategy of what's the broad question, what's the broad issue we're looking at, and then in the middle, what's the question we're actually asking of the law, and then on the right, we've coded each so that, as Scott says, behind this presentation is all of the data, the zeros, the halves, and the ones, so that we can actually do empirical work. It also means we're able to sum up those different pieces into different areas, right? So we can say, all right, all 11 of the policy issues and the law issues related to clinical treatment, here they are. And here's what portion of those 33 have actually been adopted by a given country. So when we do that, we find some really interesting and surprising trends. So to start, right, here's a picture of the map of HIV treatment about when to start. And I say this is surprising because not long ago, this map looked massively different. And there was a sea change in the science and a sea change in the policy about, do we start HIV treatment immediately, or is the guidance, which matters far more in structured public health systems than perhaps it does in the United States, where our privatized system lets millions of flowers bloom. But in most of the world, right, this kind of broad policy of when do people become eligible to start HIV treatment has changed radically in the last 5 years. And it's happened fast. Look at the globe. This policy changed in almost every country in a matter of a few years. In part, this is because there's been massive attention from the World Health Organization, from global health public officials, from funders. All have aligned to say this is the right policy, it needs to move, and it has moved dramatically. But here's the picture that I showed you at the beginning, right? Which is PrEP, pre-exposure prophylaxis. The use of those very same drugs in HIV negative people to prevent HIV acquisition, to prevent transmission. And here, the law, the science changed at the same time. The recommendations changed roughly the same time. But here we've seen far less progress. Most countries in the world, only half of countries, have aligned their laws and policies on PrEP about who's eligible and when with World Health Organization policies. Here's another example. Age restrictions on testing and treatment. So again, here the kind of global normative guidance is that actually restricting people's access to HIV testing based on their age makes very little sense. We should allow adolescents to consent to HIV because in many parts of the world, adolescents are those who are acquiring, who are getting HIV, and therefore they should be able to test for HIV. And yet in most of the world, the policy is that they actually require parental consent. Right, and this has been proven and shown over and over again that it doesn't work very well, at least in small level studies, and yet still the law environment remains a problem. Here's another one, the criminalization of sex work. Again, we see that kind of study after study, and here we have some of the rare examples of some good empirical global work out there, shows that actually criminalization of sex work drives higher rates of HIV, and yet around the world, the laws actually remain fully criminalized in most of the world. And I actually had to shift the picture that I was showing you to the left to show you one of the only countries in your bottom right that's actually decriminalized sex work, which is New Zealand, right? And so here we've got this kind of massive differences across countries. Some other interesting things we see is that we see that kind of countries have more often adopted clinical and treatment policies and laws than they have the structural and the ones that Scott was talking about at the latter that have been less evaluated. And so we can ask some important questions about why and what's going on there. And we can also look regionally. So how about what's going on in Western Europe and North America? Well, only half of countries allow migrants to access HIV services regardless of their immigration status. Only 30% have allowed nurses to initiate HIV treatment, and 72% don't allow adolescents to test without consent. And so these are the policies, again, that are backed by WHO guidance, and yet they're not being implemented in Europe, whereas others are, right? And this matters quite a bit, right? It's interesting, and I'll kind of read, I'm pulling up here. The US government, right, has a whole set of policies that it requires countries to adopt if they're going to receive funding to fight HIV in the world from the President's Emergency Plan for AIDS Relief. And yet what we find is that the US has not adopted many of those policies. In fact, there are 21 countries that receive PEPFAR funding that have higher legal adoption scores than does the United States. Here's the Asia Pacific, and we find just some interesting things as we look regionally, right? Thailand is at the top in the Asia Pacific, and we can actually look on our left side, and sorry that some of the writing here is tiny, but you can see kind of the way in which we can rank countries, and we can understand that they differ based on where the policies are. So that some countries have adopted many policies that are aligned with kind of global norms in treatment or in structural issues, but not in prevention or not in health systems issues. And so these trends, I think, tell us quite a bit. The next question then becomes, and I'm just racing a little bit to kind of describe things quickly for you here and happy to talk more about it. The next question is, do these laws matter? And which of these laws matter? And we're just beginning to start to do the kind of empirical work that we want to be able to do. But what we see anecdotally is, right, several of the countries that have made the most progress against AIDS have the most policies that are aligned with international norms. And those that have that are making seeing some of the fastest rising rates of HIV, increasing deaths, growing epidemics, those are actually the countries with the least aligned policies in many ways. And so the core question becomes, which of them writ large is going to matter the most? And this is our kind of next steps in terms of the work. This is one graph that's our very first kind of beginning to kind of look empirically. And what we see is that if we combine all of our 33 indicators, the countries with the best policy environments have seen by far they've reached the most people with HIV treatment. And we know that HIV treatment stops HIV transmission. And so it makes perfect sense that those are the countries that are making the most progress. And so there's a lot more work to be done here. But what we think is that the argument, as was kind of has been made throughout this presentation, that law is an intervention is clearest in HIV. And while we should see massive unity, given the 40 years of attention and the entire global focus on HIV, what we see actually is not unity. Instead, we see lots of differences. So we're going to continue as we go to ask core questions. Which laws matter most? Which laws matter in which combination? Because we think that actually evaluating individual laws may matter less than laws in combination with each other. And so we really want to understand how that works in the kind of legal environment. And then third, we want to understand what are the barriers to adoption and legal adoption, because we think that kind of much of the public health emphasis on looking at the science, sharing the science, and describing the science for policymakers may actually matter less than some of the political moves that are made to actually ensure that adoption moves forward quickly. So I'll stop there. Thank you all very much for having me.
I think we have so many excellent presentations today. It's like having a 6-course meal here. Unfortunately, we will go slightly over time because we've got 2 other critical presentations left. And there probably won't be much time for questions, so the speakers are answering questions directly. It's a great privilege now to introduce you Professor Shelley Hearn, who's Professor of the Practice of Public Health and the Director of the Johns Hopkins Center for Public Health Advocacy. I noticed last night on her Twitter feed, there was actually a photograph of her with the new president, Joe Biden. So she's obviously well connected. And she has also done a huge amount of work around city health as an example of legal epidemiology. I know many European colleagues are interested to hear this, to learn about her work. Welcome, Professor Hearn. I'll hand over to you.
Great. Thank you very much. And I'm cognizant of time. And I'm gonna do a little modification since I'm gonna squeeze a 10-minute talk into 5 minutes. And it is a good thing that it's a 6-course meal, and I think I'm course 5, and I'm going to borrow from Matthew Kavanaugh's work in some of the framing that he's done, which is to show the critical importance of translating the policy, the laws into the graphics, both GIS mapping, and also the what policy surveillance allows to get into the specificity of those policies and determining what works and what doesn't. And that map demonstrated the power of seeing the big picture. But what's been missing as a critical part in so much of our public health work is, while we have a commitment to evidence-driven policies, we have not been as focused and sophisticated on how do we translate that data to actually move and advocate and implement those policies in our different governmental jurisdictions. So we may know, as many of the speakers have shown, what would be the best policies for driving health, but we haven't trained, much as Scott Burris had pointed out. We haven't really developed the art and the science of how to translate that data to actually drive action. And what I want to talk about, I'm not going to give the kind of background on how we previously have used policy to drive policy surveillance to drive advocacy, but let me give an abbreviated snapshot. We long have used tools of policy surveillance, but they've been very crude ones. So for instance, an organization, Trust for America's Health in the United States, for almost 20 years has scored the US states on how ready they are for a major public health emergency, like the coronavirus event. One of the indicators that was used was again, very crude assessment. Does the state have a pandemic plan in place? Now, it wasn't in specificity what should be in that pandemic plan and should it be tested and what were the specific components to make it work, which I think, as we quite well know, those plans are only as good as they've been tested in the specific details. But it was such a crude indicator. It simply was, is the law there or not, and not into the sophistication of what are the elements that are needed. So now fast forward, here we are getting a policy surveillance where it's allowing us to do that kind of granular coding, looking for specific components that can be translated from one law to another, because as they're written from one state, from one city to one nation, they'll be variable, different languages, but this allows for a comparison that is not only helpful to ensure evidence-driven policies, but now is also a tool that practitioners can be used to get those policies on the books and working right. I want to focus in on one of the most recent examples of an advocacy initiative that has been fundamentally based on policy surveillance. Deborah, if you'll jump to my first slide. What I want to talk about is City Health. It's a US-based initiative at this point in time, a really good trial that was led by the de Beaumont Foundation and Kaiser Permanente, where an assessment was made looking at the key social determinants of health, looking at education, housing, transportation, public safety, winnowing through the data sets, building off of CDC's prevention guide, looking at the Institute of Medicine's research, looking at places like Robert Wood Johnson Foundation, and identifying what were the policies. Essentially, there were 300 that were city-based, that were a strong evidence to make a significant health outcome difference within each of those determinants of health. And then there was a pragmatism test where these policies that have been effective at city levels and that have had bipartisan support. Because I don't know if you've noticed, but here in our swirl of the United States, we're a little bit of a divided country. And in order to move issues, even at our city levels, we need to have a sense that there is an opportunity for different sides, different factions to be able to agree. Evidence helps, but having political support is really the key element. You go to the next slide. Thank you, Deborah. What City Health did was take a look at the 40 largest US cities and identify how they were doing in these 9 different policy areas. And using policy surveillance tools and working with the issue experts in each of these different areas that knew these policies inside and out, what we were able to do was create a scoring mechanism to say, okay, this is the gold standard. This is the best practices of a law. If you have the following X components, you would get a gold medal. You would be scored silver, bronze, or no medal based on a numerical scoring methodology to determine how good the law was. So you could do a cross comparison. And then the City Health Initiative would actually provide technical assistance for any city who wanted to implement those policies. So let me go to the next slide. The 9 policies, again, covering one policy from each of the critical areas of public health and social determinants of health, was an affordable housing policy, one that looked at alcohol sales control as the approach we use for improving public safety. Complete Streets is an international program, but looking at how to assure that transportation is accessible to all, regardless of age, ability, looking at streets, walkways, bikeways, et cetera. Earned sick leave many in the EU might be horrified to find out how poorly our U.S. system is in providing earned sick leave, but it was a focus there. Our food safety efforts was simply translating those inspection scores into grades, healthy food systems, looking at universal quality, high access to pre-kindergarten training, and then 2 smoking policies. One requiring age 21 for the ability to purchase tobacco. Let me go to the next slide. What was fascinating is someone who's spent a career, and as you can see from the white hair, that's a long time of doing advocacy work. Typically, what we have done in the past is when doing comparison of policies and trying to pressure local governments, state, national, international, the practice term is rank 'em and spank 'em. Typically to take the data, translate it in a way that the public and policymakers could understand, and provide the scoring. What we did here is a switch and go to rank 'em, thank 'em. And the city health data structured it so that cities were incentivized. And I'm sorry I don't have the time, but there were a number of techniques that we used that mayors, city council members wanted their medals. And simply for that recognition that they were doing right, we saw extraordinary change over this time period to move and advance the medals. All I'll say in wrapping up is that the power of data to actually be used, especially when it's granular with policy surveillance techniques and tools, it is a huge driver to go from what we know are the right policies to actually getting them in place. And I look forward to talking to many of you more on ways to actually put this into practice. I'll turn it back to you.
Thank you very much indeed, Professor Hearn. This is a topic which I think colleagues in a number of cities in Europe are particularly interested to collaborate with you and how it links with other initiatives. So we will have another specific seminar on this. It's my privilege now to introduce you, Professor Matthew Penn, Director of the Public Health Law Services at CDC. I know he's been very busy with working with the new director, and we're very keen to collaborate particularly around education and training. So Professor Penn, over to you now for our final presentation. Thank you.
Great, thank you so much, and thanks for tuning in. So good to be with friends and colleagues, both here in the U.S. And in Europe. It's a new day here in the U.S., so it's pretty exciting for us. So I know we're pretty much out of time, so I'm going to go pretty quickly. And I'm on the interwebs and the internets and have emails and stuff. So if you have questions about legal epidemiology at CDC, please do reach out directly to me. Get this. So we have a particular point of view within the public health law program that we talk about all the time at CDC. And this is the message that we bring our colleagues within the agency. Number one, law is the foundation of governmental public health system and is a significant social determinant of health. Secondly, the public health law is a transdisciplinary field, as Scott talked about. Thirdly, that a vibrant public health law community is vital to the long-term viability of the public health system and to sustained improvements in the public's health. And often talk within the agency that if we're going to make strides in life expectancy and morbidity and mortality around the US, we cannot ignore law as a determinant of health. And finally, one of the big messages that we bring inside the agency is that CDC's research on public health law should be as rigorous as its research in other areas. And thankfully, these messages are getting across. We talk about legal epidemiology as the scientific study of law as a factor in the cause, distribution, and prevention of disease and injury. And it is spreading throughout the agency, the interest and the uptake of the methods and this particular point of view. What does the law say and how does the law work? And increasingly finding folks who are interested in conducting policy surveillance studies so that we can join up our legal data sets with all the other data sets that we collect in public health in longitudinal data sets. Legal Epi within CDC is a collaborative effort. And we find many parts of the agency who make investments into the work that we do and actually give us money to hire attorneys to do this work. For this audience, a particular interest, the Center for Global Health has invested funds in studies and attorneys, preparedness and response, of course, and you see the lists here. And even beyond the formally funded investments that we receive, we've pretty much worked just informally on research projects with in-kind support and partnership with every part of CDC here over the past 10 years or so. And of course, increasingly working on issues of health equity, moving throughout 2021 into issues of the systemic racism that has been such a determinant of health in the US for so many years, and certainly working with still health departments across the country, that's state, tribal, local, and territorial health departments, and teaching them how to do legal epidemiology themselves. When we look at sort of how we do this within CDC, we do a lot of training on just Public Health Law 101. How does public health law and public health work together? And certainly teaching folks how to do legal epidemiology. So Legal Epidemiology 101, and continuing into technical assistance on research projects, sometimes providing access to data. So we collect the data for them, and then also providing services in terms of a data creation. So creating a data set for customers within the agency, ultimately coming down to the idea of collaboration. We help them to develop their scientific research questions, focusing on both CDC and still practice issues, working with them on the public health evidence and finding the relevant and important legal and policy texts, getting into the process of systematic data collection and analysis, helping them cull important information in important elements of the law, and not just looking at the binary, is there a law or is there not, really looking at the attributes and the dimensions of the law to see which parts may have an impact on health. And using an iterative process to analyze the text in cooperation with our scientific partners. And finally, down to a validation and documentation, using redundant coding for validation, documenting our results and protocols, and ultimately ensuring our partners within the agency that we're complying with HHS and CDC data policies. So what does this look like? There are concrete examples, two of which have actually come up in the previous presentations. Number one is there are a couple of attorneys who worked with Professor Comro on her earned income tax credit, one of which was brought to CDC, Dawn Pepin, as part of my office, and was trained on legal epidemiology methods as part of my team. And then the City Health project is supported with CDC funds through a cooperative agreement. So even the idea is to institutionalize legal epi within the agency so that it fits into the systems. And most of the money that CDC receives from Congress goes out the door, and we want some of that money to be going towards legal epidemiology projects. We had a team of legal epidemiologists embedded in the COVID-19 Emergency Operations Center over the past almost year now. And we resulted in two publications through MMWR. One, a smaller study looking at stay-at-home orders in a couple of metropolitan areas, a few metropolitan areas, and one looking at the whole country. Those are available on the MMWR website. Upcoming studies, we're doing an assessment of disease reporting laws across the United States, and one of the first studies that come out of that is an observational assessment of reporting of demographic data as we look to try to drive down some of the health inequities in the United States. We've got to collect the right kind of data to start sufficiently analyze how to bring those rates down. And then finally, coming up, I think next week, we're going to have a study on mask mandates in a relationship to hospitalization rates, looking at mask mandates from March to October of 2020. So, legal epidemiology is becoming more and more understood and utilized throughout CDC. And hopefully we'll have a big impact here as we move into the new administration and only increase our efforts to start to look at law's relationship to health outcomes and health system outcomes. Thank you so much. Again, my email address is here if you have questions. So thank you, great presentations, and so happy to be part of this today.
Thank you very much indeed, Professor Penn, for this is actually a critical issue. European Public Health Association, the Faculty of Public Health, and the Schools of Public Health have just completed a survey about education and training in public health law, and there's quite a deficiency. And now, particularly with the new dawn, as you refer to, there's a real opportunity to collaborate and learn across. And this is certainly an issue. We have very limited time now. Bethany Saxton from the Temple University, she's actually been monitoring the different questions. Unfortunately, there won't be an opportunity to direct questions, but I'm sure as part of this webinar series, we will have specific sessions on all the areas, because we are keen to continue this conversation. And Scott and I are very keen to develop particular projects and joint activities between the scholars and the different geographical areas here. There's three issues which, Bethany, if I can just summarize, which you've highlighted, is firstly application of methods and experiences across global systems in quantitative methods, and basically sharing the experience more widely, applying it. More information on the methods and the systems and so on, breaking down silos and education activities have been the key messages. I'm very grateful for Bethany for kindly doing this, and I'm sort of rushing through all this, but certainly we need to continue the conversation through emails which are on the screen now, and to hope that we can get one of few projects going. And Scott, who's a great supporter, and hopefully we can advocate it. There are a number of senior policymakers, scholars, and practitioners who've been part of the webinar who've emailed me separately, which we will follow up. And I'm very, very grateful for colleagues for doing this. As you know, this is part of a webinar series. Deborah, if I can have the final slides, please. And we are having a series of other webinars on a range of other issues, basically to advance the discourse, scholarship, and important practice around these issues, because lawyers is not something scholars do or just lawyers do, but we need to get this stuff into practice and to develop a real change. And this was one of the things which came out, and to strengthen this partnership. So I would encourage all participants to involve themselves in the UFA, Faculty Public Health Word Factories, and activities around that, and to join our future webinars and so on, which are on a wide range of issues. And if you want to contact us further, there is information. On your behalf, thank you very much for the speakers. Apologies for the huge pressure I put you in terms of tidying. As I said, we've had a major meal to celebrate major world events. Yesterday, I had an email that there are 2 Supreme judges in Kabul, women, female judges who were killed. So there are a whole host of legal issues and social, economic, and so on, which we need to talk about, but not within our internal silos, our own countries, but much more thinking of the joint agenda. Thank you very much indeed. Apologies, we went 5 minutes late, but I didn't want to lose this opportunity. On your behalf, thank you for all the speakers, and hopefully you'll join us at future webinars. Thank you very much indeed, everybody. Bye.
Thanks to you all.
Thanks, everybody. This was great.
Thank you very much indeed, everybody, and apologies for rushing. There was such a huge agenda. I think Scott and I were a little bit too ambitious, but it's good to have a kaleidoscope of opportunities, and if we can do a few things together to actually advise, even the small things, a few more webinars. This is a critically important agenda. Scott and I have talked about it for the last 5 years, and now he's an honorary fellow, the first lawyer who's an honorary fellow of our Faculty of Public Health, and he also has, I don't know whether I'm allowed to say this, he's got a home in Holland, so he's already one of us. So he no longer is going to just talk about the US. Shelley, I think we're very, very keen about public health advocacy.